This Week in Parasitism is brought to you by the American Society for Microbiology at microbeworld.org/TWiP. This Week in Parasitism, episode number 30, recorded on June 21st, 2011. Hi, everybody. I'm Vincent Racaniello, and this is TWiP, the podcast all about parasites. And joining me, of course, is none other, the ultimate parasite, Dickson Despommier.
Hey, Vince, how are you?
I'm sorry, you're not the ultimate parasite.
I would almost take that as a compliment because of what I used to do for a living.
What was that?
24 hours a day, 7 days a week, 365 days out of the year.
Study parasites.
I thought and dreamed parasitism.
Would that make me the ultimate virologist?
No, it would make you the ultimate host. The other laugh you're hearing in the background, ladies and gentlemen, is a dear friend of mine, Dr. Charles Knirsch, MD, MPH, who for 20-some-odd years, right, taught with me and Josh Stillman and others too, Dr. Philip D'Alessandro and others, in a course called Parasitic Diseases to the second-year medical students here at Columbia University. And many, many of them, Chuck, have, and by the way, welcome to TWiP, many of them have in their future come back to Columbia and acknowledged that this was probably the best experience that they had while they were here as an undergraduate medical student for their medical career. And it just astounds me to think that that's true, first of all. So I don't want to drink my own Kool-Aid here, but I know that we used to get terrific reviews, and obviously you did, and so did Josh Stillman. And we were a good, coherent team. So we kind of missed that, I think, yes?
Well, first of all, thank you for inviting me. It's always good to be back at Columbia, which for about 15 years really was my intellectual home after I left Montreal in medical school in Canada. And then, of course, continuing to teach after I left,
right.
Which last year was the first time in about 20 years that the course was changed and we didn't do our 3-week session together.
We did not. Did you have withdrawal symptoms?
I went through severe withdrawal, but my current employer knows how to make use of all of my time and
more.
and more. And so
that's right.
I've definitely taken that time.
So when you first got out of medical school, what did you do? Where did you do your residency, for instance?
So I came straight down to Washington Heights. That was 1985, and it was a difficult period of time for New York City in general and health in New York. And I had been in Montreal, which was the home of Osler, Sir William Osler, who wrote the first textbook of medicine published in North America. He then went on to bigger and better things, Johns Hopkins, and then actually finished his career at Oxford. But coming to New York in '85, it was still a period of time when the HIV epidemic was poorly understood. There was also a crack blight affecting behavior in the inner cities of New York, particularly in Washington Heights. So that actually a heterosexual part of the epidemic was brewing in the inner cities, of course, Washington Heights being one of the epicenters.
Right. So crack is an abbreviation for crack cocaine.
Yes, so this was the smokable form of cocaine. And of course, being in this part of the city with an epidemic that was an immunocompromising epidemic, we encountered parasites, which I presumably is why I'm here today to talk a bit about some of the parasites and some of the things that...
You are an illuminary. You are one of the leaders in our field, and we strive to bring our listeners the latest and the greatest as to what's going on. So eventually we'll shift the discussion to your favorite topic, I'm sure, which is the Millennium Development Goals and how medicine and how big pharma and how research communities are helping to move those along.
So you came to New York as a resident?
As an intern resident, yes.
Here at Columbia?
Yes.
Yeah, with Scott Hammer?
Well, so Scott was in Boston then, And I actually nearly went to do my fellowship in Boston after I finished my So I did my residency. I traveled a bit, then ended up at the London School of Hygiene and Tropical Medicine. And then I returned to Columbia as an infectious diseases fellow, assistant professor, et cetera, before.
And Harold New, I presume, was head of ID?
Harold New was a major force, I think, on this campus in medicine in general. A real doctor's doctor. If there was something that you had, whether it was an infectious disease or not, that other people had trouble diagnosing, Harold was the person you wanted at your bedside.
That's right.
And every department chair, down to medical students, when they came across a case they had trouble with, Harold was that accessible when he was on rounds.
Yeah, he was legendary.
To back up a little, what did you do in London? Were you specialized in something while you were there?
So this was a program that had been going on since the London School of Hygiene was founded, and essentially a merchant ship pulled into the Thames, and half the people were dead. It was quarantined, and the first lucky souls wearing white coats that went on then became the founders of the London School of Hygiene and Tropical Medicine.
Oh, wow.
That's how it was started. But they run a course, very international in nature, people from all around the world, particularly from the developing world, which is either a diploma or a master's program in tropical diseases, so protozoan helminths. Wonderful course taught by people that the opening lecture that I attended was by Sir Dennis Burkitt, who, of course, mapped Burkitt's lymphoma in the tributaries of some of the great rivers in Africa, and put this. The second lecture was by somebody who was, talking about how they unraveled African sleeping sickness, and of course doing lumbar punctures barehanded in the bush.
Right.
Actually did inoculation to show that it started with auto inoculation to show that lymphadenopathy started.
Huh.
And at the time, actually the same drugs that we have now.
That wasn't by Winterbottom by any chance.
It wasn't by Winterbottom, yes. So these were the legendary, figures that unraveled some of the clinical syndromes in places that were not easy to unravel these syndromes. Wow. There wasn't heavy-duty microbiome. There was no PCR. There wasn't animal models to do this work. It was putting together the transmission patterns, because there's usually a vector involved.
Sure.
And then the clinical syndrome.
Wow. So you're a specialist in travel medicine too, then?
Yes. So when I returned to Columbia as a fellow, I had, through my experience in London, but just from general interest, had experience with both diagnosis and prevention of things you really don't want to get. You want to prevent these things, but if you do get them, because these diseases aren't normally encountered. Now, New York's a big city with a big immigrant population, so we do see malaria on a weekly basis or every 2 weeks. Of course, if you were in the fringes of a city in Africa with ongoing transmission, but more likely in the rural areas, you'd be seeing one every 5 minutes, because that would be one of the primary diseases you're treating.
So here you were the go-to person for
yellow fever vaccination.
Yeah, that's right.
Whether or not to take an antimalarial.
Yep.
Complicate that by I'm 5 months pregnant and want to go with my spouse on a trip to say Cape Town, and by the way, we're going to go up to the game park. So doing a risk assessment, whether one should do that at all. And if you insist on doing it, then what would be the right medicines to take.
Sure.
So some of the more complicated travel advice, or if you're immunocompromised and want to know what's the risk benefit of taking the yellow fever vaccine if you're going into an area for business reasons or other reasons that can't be prevented. Given that there are side effects of the vaccine, the fact that there are live viral vaccines that potentially you, even though it's attenuated, may get the disease itself.
Mm-hmm. So when you came back to Columbia as a fellow,
right?
I don't think we've talked about being a fellow. Probably everyone knows what a resident is, but what does a fellow do?
So actually, when I came back in '89 as a fellow, the whole care in major teaching hospitals changed because of the Libby Zion case. And for those of you that know a little bit about this was a fairly well publicized case, both in the courts but in the newspapers, of a unfortunate woman who was given a drug while being on an antidepressant that had a severe reaction. What it did was it raised the issue of whether or not residents were adequately supervised and whether they're performing in a sleep-deprived state or not. So far from the topic of parasitism, but when I came back, the fellowship was not what I thought it would be. I thought it was going to be some patient care, but quite a bit of intellectual reading and really to a depth that you don't get to in a residency. In fact, you were the frontline supervision of the residents who were rotating on and off the ward. So continuity of care happened through the fellows and the junior attendings, which took some accommodating too, because it wasn't what I was expecting, nor were any of the fellows at that time. But, you know, as usual, the patients are there and you're there to take care of them.
So you were a fellow in infectious diseases,
right.
Again. So you saw the whole spectrum, including AIDS, which was now getting quite large in the city.
Right.
And then parasitic diseases, I've heard from Dickson there were plenty here as well.
Still are.
Did you guys meet at this time, or had you already met?
So we met in my fellowship, although
That's
I
right.
knew of Dickson. We might have met, but more after a talk he'd given, and I went up to him and said, "Oh, really?" You know, and asked a few questions. You know, Dickson is usually surrounded after his lectures by
Sycophants.
By sycophants, yes. I wasn't a sycophant, actually.
Outraged? No, that's not right.
But I did go to you for early advice. So it was when I was a resident. So you had, I'd wondered about the London program,
All right.
and I was looking for ways to fund that. And there were some grants in the city, the New York Academy of Medicine we talked about, and other things. So I think I'd approached you in my third year of residency for that.
Was Dr. Brown here at the time?
No, I never met Dr. Brown, unfortunately.
He retired back in the late 70s, stayed on a little bit after Michael Katz took over. Actually, yeah, he retired altogether from medicine in the late 1970s, but he retired from Columbia in 1970. And that's when Michael Katz came, in 1970.
But we've all benefited from his microscopy and gross specimens, which we used up until a year ago teaching.
I still have some on my shelves outside. His legacy was fantastic, of course. And then we had an adult education, sort of a clinical review course in parasitology, which we invited him back for time and again until back in the middle 80s. That's when he stopped altogether.
But just a little anecdote. So the Armory, which is wonderful now, and is when I was a resident, there was a psychiatrist, because many of the homeless people in New York, and so that used to be 1,000 cots for homeless men, all lined up in one room, which, if you can imagine, is the perfect incubator. And you now have HIV in the air, crossing epidemics with tuberculosis. And we started an outreach program, helping the psychiatry program. Didn't make our colleagues in the emergency room across the street very happy, because we were administering diagnostic TB tests, a skin test. They were positive. We were then bringing them across the street for an X-ray, and doing the right thing, but putting a stress on the hospital in the center of overlapping epidemics.
I remember that. I came here in 1982, and in the morning the men would leave. They would be bussed around the city. And then at night they would come back and sleep there. And it was not very long ago that they fixed the Armory. It's now a track. Track. What do you call it? A track.
No, it's an indoor track. It's a remarkable indoor track, in fact. But there are still as many homeless people out there. So what happened to them as well?
Well, they're out there somewhere. They're not here.
Actually, I think that example. So both controlling tuberculosis and developing therapeutics for HIV is an example of how public-private partnerships and collaboration really is the way to go. And I mentioned my chlamydia background, but I'm now head of clinical research in one of the business units at Pfizer. And we're reorganizing to actually be much closer now to academic medical centers, which Columbia now has signed up to be one of the 25 or so partners, where academic scientists, with their, whether it's a molecule or just a biologic system, can now come onto industry level platforms like high throughput screening, for instance. And so people don't realize that the next antibiotic that will be approved will have started with probably somewhere around 45 to 50,000 molecules that were synthesized, many of them dead ends in series that got nowhere. But then something that looked promising, that then was probably the progenitor to maybe 20 or 25 molecules that were optimized for less cardiac toxicity or less hepatic toxicity, but now we put a different moiety on it and we optimize for whatever organism we now want to get specific activity against. That now is going to be available to academic scientists so far in San Francisco, Boston, New York, and I think we're looking at a couple of European sites right now. So it's actually, exciting. And so HIV, clearly, without NIH leadership, academic partnerships, but then collaboration with many different entities in the pharmaceutical industry led to now the medications that, as long as you're in the developed world or in PEPFAR recipient regions of the developing world, have largely turned HIV into a chronic disease.
Mm-hmm. So after your fellowship, what was next for you?
So I was an assistant professor here at Columbia doing quite a bit of AIDS clinical trial work. Mm-hmm. So clinical trial work, which I loved. And then more on the grant side, we were doing some basic medical informatics work. So I was working with the informatics group here at Columbia, which was outstanding. And being an epidemiologist myself, my master's in public health is from here in Columbia in epidemiology, we were looking at automated decision support, particularly for the atypical presentations of tuberculosis that were coming in the hospital. Because if you're immunocompromised and develop tuberculosis, you do not look like a normal tuberculosis patient. It's actually quite hard to diagnose. But that epidemiologic pattern could lead us to put that person in an isolation room so that we wouldn't have transmission of tuberculosis in the hospital, which at a leading heart transplant center at the time was very important to protect.
Sure. And then you must have gone from here to Pfizer at some point, right?
Yeah, so went there in 97.
Why did you do that? Why did you leave?
A couple reasons. It was multifactorial. I think that I was doing a lot of clinical trial work, but I wasn't really. I was more of an implementer of decisions and designs and protocols that had been done elsewhere, either because I was an assistant professor, not a full professor, or because they were actually coming from the industry. And then, frankly, I saw people about 5 years older than me that I thought were more along the track of lifelong academics making career changes. Talked to them a lot, even after they left, and decided that I would give it a try. I wasn't sure that it was going to work, and I always felt I could return to academics, which I actually still might do at some point. But I needed to change.
And so you went right to the clinical division at Pfizer?
Yeah, I got involved with a molecule called azithromycin, and it needed. It was already approved, but there were some scientific issues about it, both in the developed world, and at the same time, Pfizer was looking at dipping its toe in the water in an international development program, an access program around the elimination of trachoma. And it actually set up a foundation with the Edna McConnell Clark Foundation to form the International Trachoma Initiative. And so that was very attractive to me because of the interest in international health. And, to redo a life cycle plan, register the intravenous formulation of azithromycin for community-acquired pneumonia was what I thought a good start. And frankly, I never expected to work as hard as I did and to be as productive as I was and as happy as I have been in this career.
So azithromycin's an antibiotic for?
It is. It's an azolite antibiotic, but it's from the macrolide family, where nitrogen's been put into the macrolide ring. What it did was it prolonged the half-life from a couple hours to about 60 hours. And it preferentially locates in white cells, and then when you have neutrophil degranulation, it releases the drug where there's infection. Wow. So when you look at sort of precision medicines, this is almost by accident a precision medicine. So what it did was, if you think about sexually transmitted chlamydia diseases or gonorrhea, where you would have, at least for chlamydia, required 10 days of a medicine that would be taken twice a day. This was a single dose. You gave a gram. Now you take the situation for chlamydia in the developing world. So these are different serovars than the genital disease. So these are oculotropic strains. And you would have had to put topical tetracycline in the eye of the whole community for 4 times a day. You could probably get by with 3 times a day for 6 weeks. Now you can imagine that. I will go 2 miles to the stream to get the water today, or I will stay at home with my 5 or 6 kids and try to put goo in their eye that they don't like anyway, 3 times a day. So, and actually, again, another public-private partnership, which is where I like to work. Get together. It's kind of the systems biology approach to collaboration. You bring people from widely different backgrounds together to solve a very difficult problem. Not easy, because those people don't always get together, but negotiate the common goals of that. So, in this case, elimination of trachoma. So with NIH funding, diagnostics from Abbott, Thermicin from Pfizer, and then academic thought leadership and drive, in this case from both the London School of Hygiene and UCSF, did a 3-country trial, Egypt, Tanzania, and the Gambia. Randomized communities to 6 weeks of goo in their eye 3 times a day, single doses of thermicin, and actually developed the evidence in a couple thousand patients to then launch and line up with the World Health Organization around the global elimination of trachoma by the year 2020.
So what did that the use of that do to trachoma?
So it's not easy going because of the communities we're involved in. And clearly there were countries that, like Morocco, Vietnam, Nepal, where the disease was going away just by overall socioeconomic development. And frankly, even in Taiwan, the disease disappeared on its own.
Why is it dependent on poor socioeconomic status?
So probably things like facial cleanliness. And in fact, the disease elimination is not a drug donation. It is a disease elimination involving the SAFE strategy, which is an acronym that stands for S for surgery, A for antibiotics, F for facial cleanliness, and E for environmental changes. So if you bring water into communities, facial cleanliness and overall standard of living goes up, the disease will go away without antibiotics. And so I think in the countries like Nepal, Morocco, and Vietnam, where you come in with an antibiotic, you're shortening the transmission period and therefore decreasing the ability, I guess not the opportunity, but what's the opposite of opportunity? The missed-opportunity to be infected multiple times with chlamydia and develop the scoring that leads to blindness.
These go from person to person, I presume.
Chlamydia is person to person, although there are certain flies. So if you go to the water well in some of these villages in sub-Saharan Africa particularly, and actually count the number of times that a fly lands on the globe of a child, they have multiple contacts per minute.
Wow.
This is done by video and then counted. So flies like muscosorbans, nasty green-headed fly, actually can pick up chlamydia on their foot pads and then land and transmit it. But in general, it's these kids have a lot of mucus from whatever infection they have. They have weepy eyes that are pus-filled, essentially. And so you can imagine that in these crowded conditions that it's easily transmitted.
And this is a problem because it causes blindness, right?
So women more than men are blind, and it's not because of any genetic background. It's because of they're the caregivers in the household, and they themselves are, since childhood, repeatedly infected. Chlamydia will clear from the eyes because of an immune response in about 2 to 3 weeks. So it's repeated infection, scarring, and then actually the eyelashes flipping down onto the globe and just scratching that causes the corneal opacity, which leads to blindness.
I just wanted to add a note of science to all of this. There is a word for those flies that carry the parasite from host to host. They're called peritonic vectors. Peritonic.
We haven't talked about that yet.
We have not.
We
just mentioned it.
We haven't written it into the book either.
Yeah, well,
it's not here. I was just going to look it up.
We don't have any eukaryotic parasites that are transmitted like that.
So the Smillium black fly
ingests the blood.
No, it ingests the blood. Just on the foot pads. No, you're right.
Yeah, we don't have any mechanical vectors.
Yes.
So you have a chapter on insects, though.
We do,
It's
a
not
big
in
one.
here.
So
Bob?
maybe in Bob's chapter he talks about mechanical vectors, but
Possible.
we tend to be interested or focus on the blood-sucking ones. Yeah.
Sure. So this is good. We've crossed the barrier between prokaryote and eukaryote. Which is the goal for all of this. I think the reason why we're doing this, Vince and I have been doing this for so long now, is that we've come to realize that the term parasitism is restricted only by the people who practice parasitology. And the fact is that if it's an organism that takes advantage of a biological system by either entering your cells or chewing off a piece of villus, those are both parasites. And I think you and I, for many years, have stressed this to the medical students too, because why differentiate between eukaryotic and prokaryotic for any other reason except that it's clumsier to try to mix all these things together? But some of the barriers are gray, very gray.
I think that the principles we used to teach, so the coevolution of humans and parasites, and the way that this happened, are essential principles, whether it's a prokaryote. I think that the prokaryote-eukaryote thing is just for cellular biologists, and that's important.
Sure.
But I think for parasitism, as you're saying, or infectious diseases in general, there are principles that apply. And I think, if you look at how long it's taken us to understand some of the modern epidemics that we've had with all of the scientific tools we have at our disposal now, and it takes very clever observation. In the case of HIV, it was actually a pharmacist at CDC that was filling orders for pentamidine for people that didn't have cancer. And, this is well documented in the band plays on Randy Schultz's book, and the band played on. You're calling by these doctors saying, so what are you treating? What cancer do they have? And then you have a cluster of cases. Then GRID was described, gay-related immune deficiency. Then work, towards the etiology, which turned out to be a virus.
What were the cancers? Kaposi's?
Kaposi's sarcoma, but that's separate. That was also with the AIDS epidemic, but these were people that had pneumocystis carinii, and people were reaching from pentamidine, and the pharmacist was saying, pentamidine is used for PCP in people with underlying immunosuppressive diseases like cancer.
Right. So
it's usually a big discovery is someone who's paying attention, right?
That's right. So I think this is why, as a group, we were so well appreciated by the medical students, because Chuck brought to his section all of these wonderful travel stories, all of these cross-cultural issues of people's behavior. The stepwell is a gathering place. There are other diseases that are transmitted there too, which we didn't cover, like dracunculus and things like that. So the knowledge base for this subject is so exciting and broad that it's very difficult not to get excited over this, to be honest. You really have to do a lousy job of teaching it in order not to interest the students because of their interest in travel.
I would frame that a little bit differently. I think that that medical students have this unbelievable deluge and onslaught of information that it was amazing that you and your leadership of this course were able to get their attention for this for you, and that's why I think you're recognized as the teacher that you are, and why a little bit that rubbed off on the rest of us.
Remember who my teacher was, Harold Brown. So that I pale by comparison, and a lot of other people too. He was a genius at getting people to listen. So that's all you have to do is just get their attention first, right? So we were all good at it because we had good role models, and you're obviously a reflection of all the great teachers that you had as well.
Right.
So Chuck, what is on your agenda now? What's on your plate? What are you excited about at this moment in your life?
So I think that we're at a real moment of opportunity in eliminating several diseases, and we could have done this with the armamentarium and the medicines that we had 20 years ago, 30 years ago. But there seems to be, despite many, many difficult conditions in the world right now, a number of wars, economic, malfeasance in our financial system, that there's the right people been connected. And I think that some of this has to do with one of the co-authors of our book, Peter Hotez and David Molyneux and others that have made the case, for a mass drug administration that potentially can eliminate there are diseases that are mentioned in the Bible that we should only be mentioned in the Bible and not in scientific publications where there's ongoing transmission. And so I think this is very exciting, and to play a small part in that community of very dedicated people is very exciting. And WHO has moved, and it's very hard to do significant work in the developing world without WHO's blessing. WHO doesn't do the work, but they need to make sure that it makes sense for the populations where you're making these interventions. And Margaret Chan convened a meeting last fall, mid-September, around the launch of the new document, which is the World Health Report on Neglected Tropical Diseases, which collects information that you and I teach and are familiar with, and have worked hard on all of our careers. So that I think that within reach, things like elephantiasis, certainly trachoma, soil-transmitted nematodes, you can go through the list with very simple interventions are within reach of elimination. Now, whether that's global or in certain communities, that remains to be seen. But if you think about it, a child that is growing up in a resource-constrained area that has 3 or 4 parasites, chronically living in their intestine, this takes them off their growth curves. There's evidence that
Sure.
they have decreased learning during this period of time. That's not a setup for a bright future. So I think these are tremendously important programs in the coming generations.
Yep.
So malaria is not one of those that...
So I also think, so the big 3, HIV, TB, and malaria, diseases that I have worked on and are critically important, kill. And so they're obvious. They have a high mortality to them as well as causing, morbidity. Have received a lot of attention and received global funding. The Global Fund funds those 3 diseases. This other basket of diseases didn't have the same advocacy alone. So what the brilliance was, it was to bundle this for advocacy purposes and also to look for the scientific and public health links for elimination.
Okay. So that's what Peter Hotez is underappreciated diseases.
Yeah, great
right?
neglected diseases.
Neglected diseases.
Exactly.
I see. Okay,
so, Chuck, how do you answer the critics that say any drug-based elimination program or control program is bound to fail because of the development of resistance?
I think that's a problem. And I think that we have to monitor for resistance. And, for the worms, it's actually hard to measure. So you almost have to look for it clinically. So you need to go back and do surveillance and
Sure.
studies. Actually, chlamydia is very hard to detect resistance. I don't understand why we haven't seen widespread resistance. I mean, this year we will in the control programs, there'll be 70 million doses of azithromycin. If you look at the donations by Merck and GlaxoSmithKline, we're talking about 1 billion people being treated with ivermectin and albendazole. Why we're not seeing widespread resistance is a good thing. It's lucky, I think, but it needs to be monitored. Ideally, a vaccine approach would be better.
Right.
And there's no doubt about that. But the diseases that if you survive it, you develop lifelong immunity are clearly the low-hanging fruit for developing attenuated vaccines. And so I think that we're dealing with in some cases, not as well understood biology. And if you look at chlamydia itself, even though the host immune system eliminates the organism, it's easy to reinfect. So you don't have long-standing immunity in chlamydia. And although we actually are working on understanding this better, multiple efforts at developing a chlamydia vaccine. Actually, one very famous vaccine was pro-inflammatory. So it caused, the opposite what you want. So if you had chlamydia and you gave the vaccine, you actually increased inflammation in the eye. So that wasn't good. So I think that, yes, the answer is we have to be vigilant for resistance. It does occur. But for these diseases, so far, we haven't seen a lot. There's concern in the schistosomiasis community now that praziquantel, which is really the only medicine. It's a great medicine, well tolerated, except as the worms are dying, you developed a response to that. Communities notice when you come in and treat with deworming agents like praziquantel because of the worm killing, which is causing a large percentage of the side effects. But there's really nothing. There are some attempts to co-administer praziquantel with oxamniquin for schistosoma mancini, and we think that might be helpful. But there's also basic science going on in antigens, both for a vaccine and models that if we wanted to go down the path of exploratory chemistry to develop new drugs would also pay dividends in schistosomiasis. It will take time.
So what does this happen at Pfizer? The basic science search for anti-parasites vaccines? Or?
So we have a collaboration with TDR, which is the Tropical Disease Research Group at WHO, where we are doing high-throughput screening, looking on established targets from academic labs mostly, with TDR fellows working in our laboratories. And so we have, it's early stage. This has been a project that's going on about 5 years, and we have things that could move into lead development. Funding for this isn't easy. The private corporations have shareholders. They want a return. We haven't been very productive in providing that return in the industry for about the last decade. And so that's where organizations and other entities like DNDI, which is the Neglected Disease Initiative, which is a public-private partnership, receives Gates money, other funding to help offset some of this work.
So you depend on those kinds of liaisons because you can't depend on selling these medicines, right?
Yeah, so the financial model doesn't work for these neglected diseases. The market does not serve the poorest people of the world the way it does the more wealthier nations, that's for sure.
It's important to emphasize, right?
Sure. The London School of Economics, though, made an interesting calculation some years ago, comparing and contrasting the big three that you mentioned before, HIV, AIDS, and malaria and tuberculosis, with these other diseases that in a single effort of sanitation, rather than vaccines or drugs, could eliminate them. They didn't consider the sanitation as an approach, but they said that if these disappeared, what effect on humanity would it be if these still remained?
Right.
And their economic assessment was that these other great neglected diseases make a bigger economic contribution to taking work away from communities and things of this sort.
So people measure that in disease-adjusted life years, the DALYs, which is this is hard to measure, chronic illness. But clearly, when you take these 8 or so neglected tropical diseases and bucket them together, they rival. They're about equal for in disease-adjusted life years as either tuberculosis, malaria, or HIV.
So over the last, let's say, 10 years, in your view, what have been the biggest successes using the approach that you've just outlined?
So I think it's too early to declare success. And I think that around the year 2020, because actually when the Millennium Development Goals were looked at in the first 5 years, realized that we weren't anywhere near where we needed to be.
Sure.
And these diseases are contributors to maternal infant health and some of the important MDGs. So I think by 2020 we will know whether it will be successful. But we've been publishing our work, and I mentioned a couple areas that are now trachoma-free. There are areas that are onco. So onco is going to be interesting. So river blindness, as it's known, it's not clear whether you can stop treating communities right now. Because we're suppressing the microfilaria, which I hope was discussed maybe in a previous podcast.
Yes, we did.
But we're not killing the adult worms. Now, we have a program out of our Wyeth laboratories.
Yes.
As Pfizer and Wyeth merged about a year ago for a drug called moxidectin. And this was also a collaborative program with TDR. And it appears to be a very, very potent microfilaricide and we're still assessing whether it kills the adult worms. I suspect it won't, because it's not entirely different. It's a different molecule in ivermectin. It has a similar mechanism of action.
Right.
Cross resistance is unlikely, but I'm not convinced it will kill the adult worms.
Yeah, we remember in the old days they used to just scoop out the nodules from the subcutaneous tissues, right?
They would do excision, particularly in Central America,
right.
where the nodules were causing quite a bit of the problems. But so we'll have to go back and look at. There are areas that have received ivermectin now for 18 years, and the disease, although it's not leading to blindness, you can't stop the medicinal intervention, because the disease will come right back and transmission will start again.
Exactly.
So at Pfizer, do you oversee all of these efforts, or do you have a focus?
So my focus is in clinical research and developing new entities. Mm-hmm. But I'm one of the more senior infectious disease people with a background in public health. So we have different governance and technical review groups, of which people in my group chair, and I. That's actually I think the fun part of my job is reviewing grants, reviewing study protocols, study concepts, as opposed to being a line administrator, which is, I think all of us have to balance the amount of administrative work we do and the amount of science we do, and the science is the great part.
But this doesn't include antimicrobials.
No, it does.
It still does.
Yeah, so I'm in what's called specialty care, which includes inflammation, infectious diseases, specialty neuroscience, endocrinology. So the subspecialty domains are lumped together, where we have about 180 or so people working on these diseases. So these are clinical pharmacologists, statisticians, and then clinicians that are doing mostly clinical trial work.
Mm-hmm.
The audience might be surprised to learn that a big pharma company is involved in these efforts in third world countries, because they generally aren't viewed as wanting to get involved because there isn't a monetary payoff.
So I think that's true today, but in the 1600s, people on the continental Europe might have viewed the New World that way too. And I think that what's amazing about traveling over the years in any part of the world, but I'll just pick a couple places that really impressed me. So I was a diplomat in China in the early 90s, but I'd been going there since the late 1980s. And to see just the human ingenuity and work and economic productivity that has occurred there. Similarly, when I've been in places like West Africa, the richness both above the ground and below the ground in terms of minerals, but in the people and their ideas and their art, their thinking. If we can be catalytic in helping address some of the diseases that are holding back economic and value creation, then what could be better than that?
Yeah, we've talked about this, right?
Yep.
You make people better so they can work and be productive and
of course
realize their potential.
Yeah, and one of the big correlations here, and I'm sure that Chuck would agree with this too, is that the more money you have, to a certain point, the more you have to spend on resources. But after that, you can spend it on luxury items. So then you're forced with making a choice as to having more children or having another luxury item. And most people obviously opt for more luxury items, provided that their children survive their early childhood. And we've noticed a decrease in birth rates in two countries, Japan and Korea, which are post-war Asian countries, obviously, but still the model is valid for a lot of other countries that haven't gotten there yet. So how do you feel about that?
So there's some big issues that, as we think about our own little disease that we're working on, I think that we have to think about planet Earth very holistically, and certainly, quality of life, the total population size, what the human condition is doing to planet Earth, all are related. I think there's some really good writing on this subject right now, but it's almost the periphery. Even if you look at climate change and what that's going on, that's not quite at the periphery, but it's a mainstream dialogue. Yet without the type of human mobilization that we know can happen. And unfortunately, we react at the last minute, so we'll be in crisis mode when we finally react. And
no question.
The interesting thing, just from more of a scientific point of view, so when you look at elimination of some parasites that have co-evolved with humans over hundreds of years, and how we've adapted to that, and now you actually don't have that stimulus during human development. One wonders what the relationship to autoimmune diseases and different.
I'm glad you brought that up.
Expression would be. So that's actually just from a clinical scientific perspective, we're going to need to be keeping an eye on. So and we teach the I don't think there's a lot of evidence for it, but actually reinfecting people with trichuris for things like inflammatory bowel disease, and doesn't mean we have to use these parasites as therapeutics, but if we understand the biology, we can design therapeutics intelligently to treat this.
Exactly. What are the targets, and then imitate those targets in some inanimate object, like
you need to do the basic science.
An implant. That's where the money sort of should be flowing, but obviously you have to triage your financing, and unfortunately, a lot of these other problems have gotten lower shelf.
If you look at pharmaceutical pipelines right now across the industry, not just where I work, but they're full of oncology agents, pretty robust pipelines, but actually also in inflammation, where many approaches have been, so the TNF inhibitors, and we now are working on a JAK inhibitor. So these are diseases like rheumatoid arthritis, inflammatory bowel disease, psoriatic arthritis, psoriasis, but that's where these are they get a lot of attention in the developed world. Those are things that
money. They bring in the money, cardiology, right? Hypertension.
Return on the investment.
Diabetes.
Right. I'm worried about whether I can still hold a fly rod when I'm 10 years down the road because of my arthritis. So, these are common thoughts for people who are long-lived. The people who are short-lived don't have these thoughts at all because obviously they just want to live. So those are big problems.
I like these global funding mechanisms, though, because I think that they can, where the markets are not serving the poorer countries, that these third-party funding mechanisms can fill in some of the gaps and create the incentives. And certainly, the Gates funding has really been a major catalytic event in both disease elimination, to their funding of things like Gavi and the vaccine initiatives, but also for funding basic research. NIH itself, fabulous, strategic work in how to deploy funding in a portfolio. At this meeting that was held to review the NTD portfolio at NIH, it was interesting to me that there are two main really big times when you spend a lot of money when you go from idea to a vaccine or a molecule. So there's before it even goes into man in that preclinical phase. So that's the laboratory work and de-risking molecules and putting them through the animal studies and the cell assays to again de-risk on safety. Then you put it into man, and it's not too expensive to go through phase 1 or 2. You've now got a proof of mechanism, even proof of concept. But to do confirmed phase development, phase 3 is the other big spend. And so this pipeline of vaccines and therapeutics I see emerging for different parasites that's been largely NIH funded is getting to the stage now where they're going to have to manage this like we manage a portfolio and make go and no-go decisions based on the available resources to go into phase 3.
Sure.
Are other large companies involved with these kind of developments, parasitic drugs?
So many companies are, both small companies in the biotech industry as well. I think that Merck was the first to do a program with ivermectin and onchocerciasis, and what I find interesting, because the big pharma companies are manufacturers, they're whatnot, but at the heart of what people are doing on the scientific side in pharma and biotech are innovating. They're dreaming. They're thinking of new things to do, and with something that may or may not happen 10 or 15 years down the road, which is how long it takes to do this work. And so I think different real experiments and just pilots and trying to do things differently have gone on, and including when you already have a medicine. And a very hard part is actually the supply chain and delivering that medicine to a place that is not easy to get to.
Yeah.
where many of these diseases are.
So astronomy, just to switch the subject, but I'll come right back.
Astronomy?
Yeah, no. They benefited greatly from collaborative efforts by pooling their resources and making use of multiple telescopes to focus in on a single object, for instance, for the radio telescope people. So has the big pharma industries ever considered setting up an independent functioning group that was a consortium of all major pharmaceutical industries to target these less popular diseases where everybody would benefit from the solution, including all the pharmaceuticals?
So there are lots of areas where we're allowed to collaborate.
Yeah.
And we call that pre-competitive, so that the collaboration gives you more than anything individually. And then there are antitrust laws about what we can work on. Although you would think that in this particular instance, antitrust wouldn't have a lot. But there is something that happened, started about 3 years ago. Bill Gates, together with the CEOs of the major pharmaceutical companies, get together for the CEO roundtable.
Right.
And this was specifically targeting diseases that were not currently on the radar.
Right.
And so that is an example of that, and they've had very specific areas of collaboration and deliverables. And also just sometimes you have to agree not to work on something together, but to not waste your time, duplicating things, working on the same targets, on the same parasites, when one entity is clearly in the lead and might as well just run with it.
Sure, but to find out what they're working on to begin with requires disclosure.
Yes.
And so that's a tough part for somebody that wants to make money on something.
Yeah, but you describe diseases that nobody will ever make money on. So this should be an agreement to work on something that that no return is expected, and but by pooling resources that
Exactly.
you can overcome some of that.
Yep. Make a donation to WHO or something like that and
Right.
step back and say thank you very much.
Well, WHO doesn't do the work. I mean, they don't really have laboratories.
But they could disseminate the drugs, that's what I'm saying.
Oh, okay, yeah. I mean, they don't do that either, actually. So
maybe they should be doing that.
No, there are NGOs that do it very well, though. I mean, and frankly, some of the other UN organizations. So UNICEF, for instance, is a very feet on the ground organization that has an extraordinary ability to move medicinal products out to USAID, actually, which has missions around the globe, and is also a network. So it's having resources in the countries, and then you can just go to Helen Keller, on and on. Actually, the one I will be going to the technical expert committee meetings of the Task Force for Global Health, which is in Atlanta. I think I got that name right. They just changed their name. It used to be the Task Force of Child Health. And they now have brought a number of the disease elimination programs under one roof, so there'll be collaboration on the access programs. Everything from a Ministry of Health filling out a report, they don't have to do it for 5 different NGOs.
Oh.
They will do deworming, trachoma, and lymphatic filariasis all in one form, organized and administered by this program.
Sounds good.
So collaboration and access is really important too.
Yeah. So that sounds like a success. I mean, I asked you about the last 10 years. That sounds very successful.
I'm not good at choosing one thing. When you say what's your favorite ice cream or your favorite television or the favorite book you read,
Favorite scotch? Come on, I know that you can pick one.
I will never answer that question directly.
Okay.
So do you think polio will be eradicated?
So we're doing some work on polio right now. Yeah. So we, at the time of SARS, in our La Jolla laboratories, we actually had a cold virus program going on because that would be commercially attractive. Well, SARS, when it first started, was pretty darn scary when you remember that.
Yep.
It spread explosively.
Yes.
And extinguished itself suddenly. We actually, under a lot of collaborative, and worries, synthesized 65 compounds that had, against coronaviruses that actually may have had activity against SARS. As it turns out, a couple of those have activity against polio. And the task force, people like Walt Daldo at the task force, who you probably know, for a variety of reasons, now believe that a couple of therapeutics, in addition to the vaccine, are going to be absolutely essential for complete eradication. So do I think we'll eradicate it? It depends on human will. I think that there is a possibility that we could repeat what's happened in Nigeria and other places where we drop the vaccine coverage, and there are hyper shedders or people out there, and we start all over again.
Yeah. Well, there was just a case report in New England Journal of Medicine. I don't know if you saw it last week. A woman in Minnesota died 12 years after being infected with polio. She died, and then they isolated virus from her, and they could sequence it and determine how long it had been replicating. So it was 12 years, and that's when one of her children had been immunized. So she was B-cell deficient. She was infected at the time, and it replicated for 12 years until it finally invaded her CNS. And there may be 1 in 50,000 such people in the U.S.,
Right.
So that could be a reservoir. So antivirals for them would be the key. Right. So she got pooled globulin every week, but apparently the titer wasn't sufficient to get rid of polio, and that's where an antiviral would be good.
Right.
If you have areas where there's an outbreak for not complying with immunization, you could go in with an antiviral, but you can't have one because you get resistance.
Yeah. So there are a couple right now, although at this stage, and the other thing is how you can't do confirmed stage development in polio.
Yeah.
You can take it up to proof. You can understand the pharmacology, maybe the mechanism, and then you'll put it on the shelf for real use.
Yeah, it is a problem. But it's interesting that you have ones that inhibit both viruses. That would be an interesting mechanism to look at.
Right.
Because it could be an RNA polymerase, something like that, which is in common with both of them, or something else.
By the way, in passing, Chuck also wrote the mode of action chapter for our textbook on parasitic infections.
Mm-hmm.
So he's not only a travel expert, but also a mode of action of drug expert.
And I have to frequently flip open what I wrote to refresh my memory. Because
As do we all.
If you don't access your gray matter frequently...
totally correct. It becomes white matter very fast.
Speaking of that, you and I have some work to do on rewriting this book.
We do, but...
This book?
The first thing I want... Yes, that book.
Parasitic diseases.
Yeah, the first thing I want to do is put it up as an ebook and make it accessible for not only the people who read it, but also the people who write it, so that you can download specific chapters at your leisure as the editions become necessary, and put it back up with a SS, or an RSS system that we can develop. So we'll talk about that in the near future, because I'm perfectly willing. I want this to go forward. I don't want to stop at the 5th edition. I agree.
I could use a sabbatical. Do that.
There you go.
It'll only be a 3-month one.
Come on, where would we take it? I can think of numerous fishing venues that this would be just great at.
Just got to get the other 2 authors now.
Well, that's a problem, because Peter just moved down to Baylor, and Bob is all set to retire. I don't know.
We can get Peter right. He said that as long as you and I are committed, then he'll start writing.
Oh, we're committed.
But until we're committed with a deadline.
That's right. Or committed to an insane asylum or something. I don't know. And I've enjoyed the collaboration here immensely. So, and that's the way you stretch your own knowledge base too, is you write on subjects that are right at the edge of what you know, but you check with all these other authors, and everybody reads everybody's chapters. It was a marvelous process of learning, which I don't want to see stop. So we'll do it. We will do it. We promise we will do it. What else is on your agenda for the next, let's say, 2 or 3 months? Where are you going? What trips are you going to take?
Yeah, so I've just come back from a number of trips. I'm hoping to hunker down, and we're going through a strategic portfolio review where we see where our different drug development projects are, which ones to pay more attention to, which ones maybe to not pay, put as much resources behind, and frankly, which ones to kill. Right. So that goes on through August. And I'm actually working on putting together a group in China right now. And so I'll make a trip over there. Hopefully I can link it with maybe a talk at an international congress, and a visit to a couple universities that I've visited in the past to see how much change has occurred there. So that's kind of it. So China in the fall.
Okay.
The ID meetings and the tropical medicine meetings are in the fall, so that gets busy.
That's right.
Just attending some of the society meetings and presenting some data that's hot off the press, that type of thing.
Great. Well.
So you said he had stories he used to tell the medical students.
He did.
From his travels.
He does.
Can you tell us one?
Yeah.
Spin us a yarn.
So, it was always fun being presented cases in different languages, actually, which most of the time I didn't understand. So many are like that. And then, of course, your own personal encounters with parasites. But I do remember once when I was in 1989, I was trying to get from Thailand to Angkor Wat. It was before really the travel to Angkor Wat was travel, but they closed the border, so I didn't know what to do. And but I found a group.
What country is Angkor Wat in, by the way?
Well, it depends on the old name or the new name.
New name.
It's in Cambodia.
That's it. Okay, fine. I just wanted our listeners to understand where that might have been.
You too, I think. Right?
Well,
otherwise known as, I guess, Kampuchea, right?
That's right, exactly.
So couldn't do that, and it was an overland bus trip anyway. And I was traveling with some people that, maybe rugged travel wasn't the best thing for them. So we actually found a group that were going into Vietnam, and I found that very interesting. And I remember, and Vietnam is completely developed now. It's actually it's a resort destination. But at the time, the farmers were putting rice out in the road for the car that would come by about every hour, because that's about how much car travel those was to do some of the dehusking. So they were laying it on the road. Trucks and cars would go over and would help with the dehusking. It was just fascinating. But I got sick in Vietnam. And of all things, I remember getting to New Delhi pretty quickly. It was part of the trip I was planning. I was staying at pretty low-budget hotels on this trip. I was younger, and I actually checked into more of a old colonial hotel. And I remember just lying in bed and rehydrating. I had a gastrointestinal illness, and the New Zealand cricket team was touring. I was watching this on TV, which is, if you're sick and you have lots of time in your hand, you just want to get better.
That's right.
You can watch a 20-hour cricket match. But as the cricket match went on, the New Zealand cricket team were getting one by one the Delhi belly, which is probably E. coli gastroenteritis, and actually were resorting to the trainers to come out and to bowl a few over. So it was
really?
It was good to see other people getting sick as I was resolving, I suppose.
That's funny. What do you think of this E. coli outbreak in Germany?
It's frightening.
Yeah.
And I think that both that and the NDM1 organism, the New Delhi. So these, especially NDM1, which is a plasmid that's not restricted to a particular species, it's in a number of species, is all I need to argue for new antibiotic discovery and development. Although the industry has deprioritized, or at least many of the companies in the industry have deprioritized.
Do you think that's because low return on investment, long periods of your clinical trials?
It's not just investment. The regulatory pathways. So a drug like penicillin, the same molecule, wouldn't get approved today. It would get stopped, because of anaphylaxis.
I see.
The rare times that it caused. So I think that there have been, some medicines that got on the market that maybe were overused and caused adverse events to a greater extent. So I think it's a combination of things. The regulatory approval pathways are unclear. I think the return is lower than medicines that you take forever for lowering lipids and things like that. But again, that's just something that if the marketplace isn't working, then you need to find public-private partnerships. That there is legislation going through Congress right now. It's called the GAIN Act, which is there's supposed to be incentives for new antimicrobial discovery and development. We've looked at it pretty carefully and given comments on it. It won't do it, but at least legislators are having the right dialogues in the right places where they can, with a stroke of a pen, change the incentives and get everybody in pharma back in.
Sure. So the big disincentives now are, besides just finances, lawsuits for these side reactions?
So I don't think that lawsuits are. I mean, for adverse events are not a big part of what goes into getting a molecule on the market. It plays a role, but it's not a huge part of it.
But I remember the swine flu vaccine development.
That was
back in the 70s with Merck and the federal government under wrote the insurance policy, and they were like Guillain-Barré syndromes afterwards, right?
Right.
And the government took a big hit from that.
So that is an example of changing legislation that has revitalized the American vaccine industry, because actually after that, most of the U.S.-based or headquartered pharmaceutical companies got out of vaccines, Pfizer included.
Yeah.
We had a polio vaccine. We had the Sabin vaccine.
Yeah.
One of many manufacturers of the Sabin vaccine. Changing that has, revitalized that so that both Merck and Pfizer now are vaccine leaders, as well as some of the European companies.
I've worked on polio for many years. In fact, I used to work with Wyeth Letterly. I think it was before they were acquired by Pfizer. And I've been involved in vaccine litigation also for polio. There's a famous Pfizer type 3 polio seed. I don't know if you know about that.
I do know about it.
And whenever a lawsuit, so typically someone will get polio from the vaccine. This is now in the 80s are the last cases. Since we switched to the killed vaccine, it doesn't happen. And one of the arguments is that the manufacturers should have switched to the Pfizer seed earlier because it was supposedly more stable. That's one of the arguments that the lawyers make. But it's not correct because it isn't particularly more stable. But the Pfizer seed, I've heard that many, many times over and over again.
Yeah, and our colleagues that are the vaccine work done at Wyeth now, Pfizer and Pearl River, it's led by a colleague of mine, Emilio Amini, who started his career at Merck, was at the International AIDS Vaccine Initiative, and he's just a good combination of good science, needs some luck in this work too, but also making the right choices, and is leading our vaccine group now in Pearl River.
I know Emilio because he postdoced with a competitor of mine, Eckhard Wimmer, and I remember him at Merck and moving around. He's responsible for the protease inhibitor development at Merck.
He did the Indinavir program, that's right, and actually had a role in Sestiva, the non-nuke.
Yep. What do you say, Dickson? Should we do a few emails to amuse Chuck? We get listener emails all the time.
That's right. Love letters. They're obviously not all love letters.
We read them on the show. The first one is from Jim, who is in Virginia. He sent us a link to an article. The Virginia Department of Transportation is considering composting roadkill, a move they say will save money and improve the environment. And Jim says, I heard 1 billion pounds of animal byproducts are going to landfills rather than into animal feed to prevent the spread of mad cow disease. So is this better to compost it rather than put it into animal feed?
Well, in my view, composting meat or any animal protein is not as efficient to make up good soil as vegetable material. So I think it's a bad idea probably all the way around.
Okay. There you hear it from Dickson.
That's my view.
The next one is from Peter, who sent us links to 3 New England Journal articles, one on cutaneous leishmaniasis. And I think I've shown you this figure before, Dickson, but this is a photograph.
Oh, yes.
Cutaneous leishmaniasis.
Yep.
A 25-year-old man in Iran. So that's expected, right?
Sure.
It's a case report. And then there's another one, hookworm, cutaneous larva migrans.
See, we have a following, Chuck. We've got a following.
There you go.
Look, creeping eruption.
Is that what that is?
Yeah.
We'll have to post these links. 42-year-old man.
Ancylostoma caninum.
Where was he?
Could have been anywhere.
Doesn't say.
It looks pretty nasty,
Singapore.
Though. Looks like it was secondarily infected, don't you think?
And finally, chronic schistosomiasis.
Oh.
Yeah.
Yes.
Oh, my.
Tortuous varicosities.
And he has portal hypertension.
He's got portal hypertension.
Yes.
Wow.
We talked about
the
that.
cirrhosis, which you did talk about.
Oh, sure.
Alzheimer's pipestem cirrhosis.
You have to listen.
34-year-old
Chuck's going to become a big fan.
It's a Brazilian man. So what could you do about this?
Well, you can do a lot of things.
Surgery?
Well, they used to have a shunt for this thing. You could do a portal shunt. Mm-hmm. And that's actually what that vein is. That's a portal shunt that's left over from embryological development. So you can shift that surgically. And you can actually force the worms to migrate onto a filter that you can collect them on and get rid of them. That's the Goldschmidt technique that was invented over at Cornell But they don't do that too much anymore because of the advent of praziquantel. But still, this is a guy who probably lived out in the bush for a long, long time before he saw medical
This is pretty end stage, too, because...
it's pretty rare nowadays. But still, it's very dramatic whenever they encounter it.
So they treated him.
Yep.
And he's doing well, it says.
That's good.
Well, more than 200 million people worldwide are infected with schistosomes, it says here.
Absolutely. Harold Brown used to make a presentation to the medical students every year of a perfectly normal-looking and feeling person who had just been recently diagnosed with schistosoma mannsoni from Puerto Rico. And he would interview the guy, and he said, "How do you feel?" And I said, "I feel fine." And how long have you been sick? He says, I haven't been sick. He says, but yet you have a parasite in your blood. And so then he shows the eggs, and he shows what could happen if not treated. In those days, the treatment was much worse than it is today. But it was a lesson was that you can't diagnose these infections based on symptoms. Yeah. You have to look in the lab and make the diagnosis that way, too.
All right, thanks, Peter. The next one's from Colleen. This is perfect for Chuck.
All right.
My question is, can a traveler to a South American country acquire a bacterial infection that lies dormant after an initial presentation of high fever, headache, and GI disturbance, with recurrence of bowel issues months later? Are there bacteria that can lie dormant for months and have recurrence of acute symptoms?
So I would need a little bit more information about where in South America. But in general, bacteria that have GI manifestations are self-limited. That's the usual.
Right. What protozoans would you think of, though, Chuck?
So you're the protozoa expert.
But I'm shifting.
Yeah. Well, this constellation. So the headache could be as a result of high fever and GI. So the first thing I would worry about would be things that are very worrisome. In South America, you can get Vivax malaria. So I would be worried, especially with a recurrence pattern. I would be worried about things that actually, left untreated, can cause serious morbidity, including even death. The Vivax malaria usually doesn't cause death, so I'd be worried about maybe one of the Vivax malarias, and then I would go do some routine screens for GI. Amoebiasis sometimes would present in this fashion. Although the recurrence piece, it's usually progressive, and it can lead to liver disease. So.
Maybe Giardia.
Giardia, actually, I don't see anything in here about weight loss. Over many months, you'd expect, a 20, 30-pound weight loss with Giardia.
What about blastocystis?
Yeah, so, blastocystis is always debated about whether it's a pathogen or not.
It's true.
I think most people would err on the side of, worrying that it is a pathogen.
Yep.
But I would be going after the things that really we know are worrisome.
Of course.
And untreated can cause significant morbidity.
And then after eliminating those, you're stuck with all these leftovers like Endolamics nana and Iodomia botulinum.
Right. Again, not sure how pathogenic they are.
No.
And this looks like something with high fever, headache, and GI. The high fever is what I'm queuing in on, and why I would rule out malaria first.
That's right. So Harold Brown, again, going back to our mentor, would say, well, this person could have had two things, and one of them went away. The one that caused the high fever is gone, but the one that didn't go away was the one that causes this chronic intestinal infection. So teaches you to keep looking no matter what, and that's where Harold knew, and also Glenda Garvey, another colleague of ours, were very good at persisting. They never took a simple answer for the final answer. They always kept looking for other causes.
Did they think zebras?
Always. Every time.
All right, Colleen. Next one's from Scott. I can't be the first one to think of another TWiP is hosted, can I? The end of the show. Another TWiP is hosted. Keep up the good work. Ben writes, the subject of Ben's email was an odd thing about Texas. Recently, there's been an explosion of stumbling poultry disease in my neighborhood in South Texas. It abounded. I think he said it goes away. It went away after all the nearby guineas died and stopped eating the ticks. This makes me think of Babesia, but one of the neighbors thinks it might be a worm. Would this classify as a parasite? Have you ever heard of anything like this before?
I'm not a poultry expert here.
What would Babesia do?
Babesia is a bloodborne parasite.
Not tick-borne, is it?
It's tick-borne.
It's
Yeah, it
tick-borne,
is. Sure,
too,
it is.
yeah.
Sure. In fact, it was the very first disease shown to be transmitted by a vector.
That's right.
It's this
I remember
Texas
that,
fever,
yes.
Lone Star fever.
Texas shipping fever?
That's right. That's Theobald Smith was actually the one who showed that first. So the point is that chickens, I don't think, I don't know if they get Babesia or not. I have no idea. Chuck, do you have any idea about that?
I'm not aware of that occurring. I think that,
When I think of chickens and stuff, I think of coccidiosis. I think of a disease like we used to call it the Frank Perdue disease because they were desperately worried about it getting into their chickens because it really reduces their weight and weight loss and stuff. But this one is, I'd like some more
information, Ben.
I want some more information from other listeners that have expertise in
veterinary medicine.
Yeah, you bet.
We have some.
We do. We've had some nice emails from vets.
Ben says, P.S. You guys are my fave.
Hey.
P.S. You don't have to read this, but I don't mind being read. Next one's from Benjamin. I'm the one who wrote you about stumbling poultry disease. Oh, it's Benjamin again.
Again.
Two things. On T. Gondii, Vince asked Dr. Despommier a how question about toxo, to which Dr. Despommier said something to the effect of, Vince, I believe in creationism. I resemble that remark. I think he says, I resent that remark.
Yeah,
and would politely ask you to refrain from doing so again, at least as a joke. Okay, Dickson, you've been chastised.
Sorry, Benjamin. Didn't mean to offend.
Second, on TWiP 19, Dr. Despommier mentioned that some kids have pica. It's pronounced pica, not pica. Pica is a small rodent that lives in South America. There you go, Dickson.
Well, Benjamin, you should be helping us teach this
That
course.
Webster's or Oxford English, do you think?
What did you call it when you were in school, Chuck?
I call it pica, too.
Yeah, me too. Well, that's how I heard it, so that's how I pronounced it.
We might as well read the third email from Benjamin. To wrap
he
it
wrote
up.
3 of them.
I was just listening to TWiP 15.
Uh-oh.
2 more things. At the end of TWiP 18, Vince randomly says, your narration is impeccable. Have you fixed this? Maybe it was just an editing glitch. It just disturbs me late at night when I have trouble sleeping. I just said it randomly. Greetings from South Texas, the home of the golden-cheeked warbler. P.S. Dick's volume keeps me on my toes, trying to keep from hurting my ears. Something to look into. I think you talk loudly and softly. That's what he's complaining about. Let's read one more here from Ivan. I write from Cozumel, the island on the Caribbean, and I found your podcast of Strongyloides stercoralis, which I think is great. I was looking for data and pictures of different parasites, and I would like to know if you can help me identify the species of this parasite that I start seeing very often in my practice. I think it's Ankylostoma caninum, but I'm not sure. I would appreciate your help. I attached the files with the pictures. Excuse me for the quality of the images, but the camera in the microscope does not allow me to take better pictures. All right. I have to show you these pictures. Maybe you guys can... see, what's this guy's name? Ivan?
Ivan.
TWiP.
See, we run a virtual diagnostic lab here also, Chuck.
Here we go. Now you guys tell me if you can.
I have to put my glasses on for this one.
These are his pictures, but I don't know if you can see... Should I blow them up for you?
Blow them.
Here's one. So I guess this is...
That's a plant artifact. Next.
It's a plant artifact?
Yeah, notice that the end is blunt and it's kind of rough-edged. There's no structure inside.
Okay.
That's another one over here. That's a plant artifact.
Let's look at this next one. Same thing?
Got a plant artifact there, too. Keep going.
You mean it's in the... What are these from?
It's from stool.
Stool?
Yeah, from some food stuff that he ate. That's a plant artifact. Those are all... Sorry to say this, but you're not dealing with a parasite in this case.
Gusanos, which is...
No, I can't see anything here.
Nope. Well, your microscope looks like it's functioning perfectly well. There's just no internal structure in any of those little hair-like structures that are left over from eating something of a plant nature. Okay, we call them artifacts because they confuse beginning technicians as to whether they're a worm or not. But if you look at enough stool and you see enough worms, you can easily tell them apart.
He says he sees it in his practice. He's a vet.
Well, maybe his pets are eating some
plant material
product that comes through, but those are not, I can guarantee you that the ones you sent us, at least, were not parasites. For those reasons.
All right, one more. Dear Vincent and Dick, Liam. Thank you both for reigniting my interest in these fascinating organisms. I'm a medical student from Western Australia with a particular interest in infectious diseases, although our clinical teaching seems mostly oriented around bacteria, viruses, and the occasional fungus. I have only recently discovered these podcasts, but I have found them immensely educational and entertaining. If I might offer a suggestion for a future episode, you seem to have avoided the free-living neurotropic amoebae such as Naegleria, Acanthamoeba, and Balamuthia in your episodes about protozoa. While they might be considered opportunists rather than parasites, Naegleria in particular causes one of the deadliest eukaryotic infections, and I would be very interested if you could offer some further insights.
Hear, hear.
Can we do that?
Yeah, of
We
course.
actually, and you were involved in it, Dr. Despommier.
Yes,
I
Dr.
presented
Knirsch.
to inner-city rounds, infectious diseases rounds, about 1990 or about 1989 or 1990. An unfortunate woman who had Acanthamoeba encephalitis.
Right.
She was an AIDS patient,
Yep.
and we did get a postmortem and presented that.
You bet. So you've just created a reason for us inviting you back, because you can lead the grand rounds on this one. How's that? I'd be glad to have a session on that.
Yeah, these are rarely diagnosed and rarely recognized even when they're in patients, and
right.
quite Naegleria particularly is a frightening disease.
There were a couple of outbreaks in Australia, in fact, involving, it requires superheated water almost to just allow that organism to survive, and everything else doesn't. It got into some swimming pool water, and people were diving in, and it was going through their cribriform plate into their brain. So I understand why there's an interest in Australia, because they still remember those outbreaks, and they want to prevent them. There were a couple of cases also in Bath, in England, where they they had to drain the baths, the Roman baths that were still in operation, because someone had caught an Acanthamoeba infection in that direction as well.
All right, let's do an episode.
Yeah, we can.
Okay.
I'd love to. Chuck, you willing to come back?
Be glad to come back.
Liam,
Excellent.
Liam, see, from Western Australia, medical student.
Okay.
We have a long reach.
It's Liam or Aleem?
Oh, you're probably right.
Okay.
That actor, Liam Neeson, that's how you say it?
I think that's how he
Sorry,
spells his
Liam.
name.
Pika, not Pika.
Whatever. You say potato, and I say storm door.
All right, that'll do it for TWiP. You can find us on iTunes and at the Zune Marketplace, or at microbeworld.org/TWiP. If you like it, go over to iTunes and leave a brief review. It helps us to stay on the front page. And, of course, send your questions and comments to twip@twiv.tv. Chuck Knirsch, thanks for coming.
My pleasure. Thank you for having me.
From Pfizer. Right. I was always amazed that in New York City there is a pharmaceutical company.
Founded in Brooklyn in the 1800s.
So there's science done there, right? It's not just corporate offices, right?
We do clinical development there. Our laboratories are in other places.
Good. Thanks again. And Dickson Despommier, thank you, as always.
It's my extreme pleasure.
Trichinella.org and verticalfarm.com and medicalecology.com, right?
Yep.
We'll name them all.
Yep.
And you're building a lot of vertical farms, aren't you?
There are 5 now.
Can I have some lettuce?
Sure.
Parasite free.
That's right.
So there's one in Korea,
Yes.
Singapore,
Not yet.
Holland,
Yes. Japan.
right? And
One going up in Manchester, England. And today I received an email from a friend of mine in Seattle. They just completed all of the renovations on a 2-story vertical farm. Modest, but still, 2 stories is 2 stories.
so none of these are yet functional, right?
No, that's not true. The one in Korea is. The one in Japan is.
So they're making produce.
They are
Did you
making
eat?
produce.
Did you eat some of it?
I
That would have
did.
been symbolic. Yes?
No, while I was in Korea, I actually
good.
did eat
How did
some.
it taste?
So it was
Horrible,
great.
right?
No, it was terrific. it was wonderful. You didn't have to wash it or anything. You just pick it up and eat it. Because it's done.
And then you got sick a few days later, right?
Exactly, and then I went to Chuck and no, that was not true at all. No, it was great. It was actually great. So in July, I'll be cutting the ribbon on one in Manchester, England.
Really?
Yeah.
Make sure
So
they take pictures,
5.
Dixon.
I certainly will. 5
Just
of them.
months ago, you were
There were none.
despairing that there were none.
Exactly.
Now you have so many.
Well,
Very good. I'm happy.
I think the world is happier
Yeah.
that they're there.
Dixon is happier too.
Remember, I have no vested interest in any of these. I just wanted to see them done. That's all.
Yes, I
That's
can tell
happening.
your wallet is thin.
That's right. And those are all singles anyway.
I'm Vincent Racaniello. You can find me at virology. WS. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back next week. Another TWiP is parasitic.